Today we're going to talk about bipolar disorders and nursing care of persons with mood lability. Our objectives today, after this lecture, you'll be able to discuss the role of mania in mental disorders, describe theories explaining bipolar disorder and mood lability, identify evidence-based interventions for patients diagnosed with bipolar disorder, develop recovery-oriented strategies that address the needs of a person diagnosed with bipolar disorder, and develop wellness strategies for the person diagnosed with bipolar disorder. First, we want to talk about mania. This is one of the primary symptoms of bipolar disorder, and mania can be recognized by an elevated, expansive, or irritable mood, sometimes grandiose delusions or unusual self-confidence, pressured speech or more talkative than usual. And this could be difficult to interrupt. This is usually a very unnatural kind of speech that feels very rushed and fills all the gaps where there's no silence. Sometimes a flight of ideas or racing thoughts, and these are just a lot of different ideas that comes to the person's mind, and they're talking about all these different kind of avenues, and they're not really interconnected. And the racing thoughts, being unable to turn off all these thoughts that are happening in their head, kind of like a motor running in their mind. Increased distractibility, and their need for sleep is decreased, but their energy is very high. Sometimes these patients, they may only sleep for 1 or 2 hours a night. So you can imagine they're very sleep deprived, but they have very high energy. This devolves into hyperactivity, agitation, and very disorganized behavior over time. And this impairs their social activities, their occupational functioning, and interpersonal relationships. Additionally, the impulsivity and high-risk behavior, there may be excessive involvement in pleasurable activities with no regard to consequences. And this could be anything from sexual infidelities to gambling, excessive debt, just large purchases, giving away items with no regard to the consequences. Individuals experiencing mania often need hospitalization for their own safety and for stabilization. Mania is not exclusive to bipolar disorder. It's also associated with schizophrenia, schizoaffective disorder, anxiety disorders, some personality disorders, sometimes substance use involving stimulants, adolescent conduct disorders, but primarily it's found in bipolar disorder. Occasionally, it could be found with some metabolic abnormalities, including neurologic disorders, tumors, and sometimes the side effect of some medications. When we talk about mood lability, what that really is, it's alterations in mood with little or no change to external events. So whatever's happening in the environment around them is not causing their change in mood. Rapid cycling is a form of mood lability, so that's kind of going in and out of these up and down phases where they're really happy and excited and impulsive in a pleasurable way to really depressed and down and maybe impulsive in a negative way. In severe forms, this continuous cycling between the threshold of mania and depression or hypomania and depression can happen. There are 3 different types of bipolar disorder that we are going to discuss. There's bipolar 1, bipolar 2, and cyclothemic disorder. So let's start talking about bipolar disorder 1. There's a graph here in your PowerPoints. I think this visual is really great for representing how bipolar 1 presents. There are peaks and valleys, so highs and lows. Someone with bipolar 1 has a really high peak of mania, usually followed by an intense low valley of depression. And so that's how we see bipolar 1 is very high peaks of mania followed by a very low valley of depression. Bipolar disorder 2, the difference in this, if you are looking at the graph, the peak of mania is much smaller. It's still there, but it's smaller, and that is called hypomania because it's smaller. The valley of depression is almost the same. So even though they're not as manic in bipolar 2, they still experience severe depression when they go into their depressive state. With cyclothymic disorder, they cycle in and out of this hypomanic state and into a depression state that's not quite as depressive as bipolar 1 and bipolar 2. But they need to cycle in and out of these hypomanic and depressive states for 2 years before it's diagnosed as cyclothymic disorder. Therefore, it's often misdiagnosed as bipolar 2 or simply as depression. And the reason for that, bipolar 2, is because of the hypomanic phase is sometimes picked up by a physician first, or because of the peak of depression isn't quite deep enough for it to become obvious to someone that this is bipolar disorder. Now, signs of a manic episode include euphoric and intensely excited or happy, having more energy than usual, insomnia, speaking fast about several different things at once, having jumbled thoughts, or doing uncharacteristic and risky things. Sometimes people in a manic state, they feel really good about themselves. And a lot of times when someone feels really good about something, they're not likely to report it to someone as a problem, right? They like staying in this phase. When it becomes a problem, when they report and seek help, typically is when they have the depressive episodes. And this is when they have feelings of hopelessness, little to no energy, sleeping too much or too little, eating too much or too little, or if they have thoughts of death or suicide. Once they get into a depressive phase and the mania comes down, they may be realizing that they have to deal with the consequences, the ramifications of their actions while they were in their manic state, and that can be very devastating to them. So in bipolar 1, we have this classic manic depressive disorder with mood swings that alter from being depressed to manic. Our elevated mood, which is euphoric, exaggerated feelings of well-being or elation, feeling high and ecstatic, okay? An expansive mood, so lack of restraint in expressing their feelings. They have this overvalued sense of self-importance, constant and indiscriminate enthusiasm for interpersonal, sexual, and occupational interactions. They also may become irritable. So they could have an irritable mood where they're easily annoyed, provoked to anger, and have difficult maintaining social relationships. In general, any one of these 3 bipolar disorders, it's a chronic and cyclic disorder. It has an early onset, and usually there's a family history of the illness that's associated with multiple episodes or continuous symptoms. It's not uncommon for someone with a first-degree relative to also have bipolar disorder. This can lead to severe functional impairment such as alienation from their family, their friends, their coworkers, indebtedness, losing their job, ending up getting divorced, or any other problems of living. So diagnostic criteria depends upon at least one manic episode or a mixed episode and a depressive episode. So they have to have a manic episode and they have to have a depressed episode. Sometimes they have a mixed episode, and what that means is that they can experience mania and depression at the same time. And this is when they have extreme anxiety, agitation, irritability. and they're at high risk for suicide. One way to explain a mixed episode, where they're kind of having symptoms of both mania and depression at the same time, is like a person saying, am I depressed because my mood is low and I'm hopeless, or am I manic because I'm restless and don't seem to need sleep and I'm impulsive? So it could be a mixed episode. When we talk about bipolar disorders across the lifespan in children and adolescents, depression is usually occurs first, and it's marked by intense rage, because remember that children, when they experience depression, are not usually sad and withdrawn and kind of stay in their beds. They usually express their depression by anger and irritability and rage. Symptoms reflective of developmental levels, their age, of course. Children can include attention deficit hyperactivity disorder or conduct disorder. Okay. When we move on to our older adult population, greater neurologic abnormalities and cognitive disturbances, an increased or incidence of mania actually decreases with age. So we'll see more depressive episodes, less manic episodes. Significant symptoms usually appear before the age of 25. Like most of our mental health challenges that we talk about, these symptoms are going to appear late teens, early 20s. There is no gender difference in the incidence of bipolar, but, but female patients are at greater risk for depression and rapid cycling, like going in and out of those manic and depressive states, than men are. But male patients are at greater risk for having manic episodes. Generally, male patients are more impulsive than female patients, and that puts them at higher risk for mania. There is inadequate research to determine the impact of race and ethnicity on the morbidity of people with bipolar disorder. So it happens across all ethnicities. Bipolar disorder can devastate families and partners. There is this emotional merry-go-round. Dealing with the consequences of their impulsive behavior is a major problem. There could be excessive indebtedness, assault charges even, or sexual infidelities. Family therapy is definitely something that is needed in order to keep family units together and to provide good support at home. So things that lead to relapse, stressful life events, medication non-adherence, or disruption in the social rhythm. So working towards recovery, some of our goals for treatment are to help the patients identify the things that are going to lead them to relapse. Some treatments include medications, psychotherapy, education, and support. Many patients are treated initially in the primary care setting. Again, it's often misdiagnosed as depression in the primary care setting, leading to a delay in proper treatment because people don't often seek help until they're having those depressive symptoms. The problem with that is if they're prescribed an antidepressant, which is going to elevate their mood, right? So if we give them an SSRI and that increases the serotonin levels in their brain, and they're going to feel better and they're going to feel happier, and then they start to go into a manic phase. Now we've made them too happy and they're really going to go into a manic phase. So typically SSRIs or any other antidepressants are really not the best choice for patients with bipolar disorder. So prescribed antidepressants can precipitate manic episodes. Safety is always a priority during a manic episode, because our patients have poor judgment and impulsivity that lead to these risk-taking behaviors. And then, of course, after the manic episode, they may be devastated by the consequences of their impulsive behaviors, and this puts them at a higher risk for suicide. We want to make sure we do our health assessments, our physical assessment first. Remember, if our patient is saying that they have a suicidal ideation or making suicidal statements, that would be our priority. But if they are not making those statements, then our priority is our physical assessment. We want to look for changes in the severity of their activities, their eating and sleep patterns, because we want, especially sleep patterns, because they may only be sleeping 1 to 2 hours a night. We're going to be looking at their diet and body weight, any laboratory testing like thyroid function and electrolytes, changes in sexual practices or partners to see if they need STI testing, pharmacologic assessment, so what kind of medications they're on, over the counter, any herbal supplements, any use of alcohol or other substances, especially stimulants. And then we can do their psychosocial assessment, their mood, their cognition. How's their thought process right now? Are they having any thought disturbances? What are their stressors and how do they cope right now? What are their coping skills and what can we do to help them better cope? And then do a risk assessment on them. Evaluating their strength assessment. So again, this is not how much can they bench press at the gym, but this is what are they already doing well. So we should always listen for thoughts, feelings, or behaviors that could be identified as strengths. They might not even recognize what they're already doing as something that they're doing well. So some things we could ask, or some things we could be thinking about while they're talking, or what healthy behaviors are they already routinely practicing? Are there any cues for their manic or depressive episodes? Who provides emotional support for them? What do they do to relax? How do they manage their stress already? What makes them feel good when they're on their medications? And we're talking about like when they're feeling stable. And how do they remember to take their medications? Do they leave their medications next to the coffee maker? Do they have a post-it note on their mirror in the bathroom? Like, what are they doing already that's well? And we're going to encourage them to keep doing that and build upon that. Providing a therapeutic relationship is really important. We want to remain calm, avoid any arguments. Walking with the patient while talking, if they're really high energy and they feel like they can't stop moving, it would not be beneficial to try to make them sit at a conference table, in their bed, at a chair, even to sit down for meals. If they have a lot of energy, pace with them, walk with them. As long as they are safe, they're not interrupting other people, and they're not harming themselves or others, give them the space to do that. Give them the space to avoid agitation, and then use periods of stable mental health to focus on stress reduction, illness management, and relapse prevention. The only time they're going to be able to take in a lot of new education, information, and be able to really interact with you in a meaningful way is going to be during periods of stable mental health when they're back at that baseline. Developing some wellness challenges. Many need self-care interventions and different wellness strategies. Individuals are more sensitive to life events, so we want to find out on an individual basis like what is happening in their lives. Focus on strengthening their coping skills, maybe ones they're doing already or incorporating new ones, and perhaps creating daily challenges. And so on this slide, I included just a little self-love kind of mental health challenge daily activity. Where like day one, they can pick one thing to do that day, meditate, yoga, or go outside or journal. Day two, make a to-do list and add the little things and see how much you can get done in a day. So each of these things is just something that they can do, they can check off, and they feel like they've accomplished a goal. And again, it's a SMART goal. So it's measurable, it's obtainable, like it's in a reasonable time frame. When we talk about mood stabilizing drugs, I want you to hone in on lithium. So lithium carbonate is our most commonly used, most commonly prescribed drug for bipolar disorder. This has been used since 1970 and has been proven to be very effective in stabilizing patients with bipolar disorder. So mood stabilizers are primarily for treating bipolar disorder, and while they're helpful, they do not cure any mood swings. They just make it so that they're not as severe. Lithium is a natural occurring element that's been approved by the FDA as a mood stabilizer since 1970. You need to know all about lithium. Some other medications that are mood stabilizing drugs are Depakote, Tegretol, and Lamictal. Information that you need to know about lithium: the therapeutic range for lithium, 0.6 to 1.2. Anything above 1.5 is a toxic level. You need to understand that toxic signs and symptoms may include blurry vision, tinnitus, slurred speech, convulsions or major tremors, excessive urination and thirst, and ataxia. Kind of think of these things as cognitive impairments, right? So, cognitive issues, ringing in the ears, blurry vision, slurred speech, convulsions, tremors, like um, major shaking, clonic type seizure activity, excessive urination and thirst, and then having, you know, shuffling or unsteady gait. Normal adverse reactions: nausea, vomiting, think GI stuff. This is normal. Drowsiness, fatigue, being thirsty, but not excessively, having a dry mouth or a metallic taste. Metallic taste is normal. And having weight gain. Those are normal adverse reactions versus what's going to cue your mind of a toxic level. Education for patients: you need to teach signs and symptoms of toxicity. Serum levels need to be checked every 1 to 2 months. We want to tell them not to operate any heavy machinery until they've adjusted to their dose. They need to avoid being dehydrated. They need to drink plenty of water. They need to avoid low sodium diets. Decreased sodium levels actually increase lithium levels. Avoid in renal patients, so contraindications for lithium. Avoid in renal or cardiovascular disease. Avoid giving diuretics with lithium. Why? Why would we avoid giving diuretics with lithium? Because they flush out the sodium, right? And if we have decreased sodium levels, then our lithium levels are going to be too high. We want to avoid NSAIDs. Why? Because they can decrease renal flow, and this will increase the risk for toxicity. Be careful in clients with vomiting or diarrhea due to loss of electrolytes leading to dehydration, or dehydration from fever or sweating. Again, because then we're losing sodium, right? Losing sodium with dehydration, losing sodium with sweating or any electrolyte imbalance. And this could cause toxicity. This is a pregnancy class D. It is not recommended for pregnant individuals. They would need to be switched to a different medication. They would have to be hospitalized and come off of this medication. So important goals for our psychosocial interventions: identify risk factors and develop strategies to address them. Help the patient understand what's happening, because this could be pretty frightening for them and mentally exhausting. Partner with the patient to develop these strategies. Make sure that they're included in their care. Enhance social and occupational functioning. Improve their quality of life. Increase patient and family's acceptance of this disorder. So this may include, family education as well, which we'll talk about soon. And hopefully reduce the risk of suicide. Teaching points for patients and families, mostly for families, is recognize the warning signs and symptoms of a relapse. Families might notice that mania is starting maybe even before the patient does. And develop an emergency plan for recognizing and then intervening if a relapse occurs. helping families to encourage medication adherence, making sure that their loved ones are taking their medications every day, weight management if people are eating too much or too little, psychoeducation, making sure that the patients are getting to their therapy appointments or maybe even having family therapy appointments. If this is a child with a disorder or a teenager, there may be additional parenting skills needed, intervention for family members. The goal is helping the family understand how to cope with the disorder, and this ranges from occasional counseling sessions to intensive family therapy. And that is the end of my bipolar lecture.